You're listening to Beyond the Endpoint, a podcast from the Duke Clinical Research Institute. In this series, we're demystifying clinical research and answering your pressing questions about health and healthcare. You can find our full episodes at dcri.org/BTE.
Hello and welcome to Beyond the Endpoint. My name is Dr. Emily O'Brien and I'm one of your co-hosts. I'm bringing my perspective as a researcher with the Duke Clinical Research Institute, or DCRI, where I study population health, and I'm delighted to be here with my friend and co-host, Jenny Cook.
Thanks, Emily. As a communicator, I share research results to a broader audience, people outside of academia, who are often interested in the latest findings from our studies and what it means for them. In today's episode of Beyond the Endpoint, we're going to be chatting with Dr. Tony Galanos, a researcher and physician who does some research translation of his own, though for a slightly different audience.
Dr. Galanos has done some really incredible things here at Duke, including an 8-week course on grief that's aimed toward medical students and residents. And it's one of the first of its kind in the country, and I think has inspired a lot of additional interest and work in this space, which is great to see. As we'll touch on today, healthcare providers have historically been discouraged from discussing the emotional toll that their work can take. And through his research and courses, Dr. Galanos is working to shift this dialogue around grief in the clinical setting.
But before we introduce Dr. Galanos, we wanted to talk a little bit about the public perception of this topic. What do those of us who aren't in healthcare, who aren't clinicians at the bedside, what do we know about what it's like to be in a workplace that's sometimes defined by illness and death? Emily, driving in today, I was listening to the radio, and Taylor Swift's "I Can Do It With a Broken Heart" was playing. The perfect sort of song for this episode today of, faking it until you make it. It reminded me of all 27 or 28 seasons of Grey's Anatomy, where the fictional doctors and healthcare staff go through plane crashes and bombings and war and all kinds of things. And the very next episode, they bounce back and have a new romantic interest. I don't think that's what it's like in real life.
I have not caught all 28 seasons. I'm working on that as we speak. But you're right. It is. We all know it's fictional, but it does sort of imply this culture of dealing with every possible tragedy that could ever occur, the unluckiest group of people alive, and then getting up and sort of shaking it off and doing it again. One of the things that I've been hearing a bit more about recently is this concept of the hidden curriculum. Have you heard about that? Or
I haven't.
That? It's this idea that, these sort of bright-eyed, idealist medical students start. They sort of learn, so much information about science and the body in their textbook, but then there's this additional type of learning that's more behind the scenes and this sort of informal or unspoken set of lessons about how to be a doctor. And that one of them is this shake it off concept, do it with a broken heart. And over time, I think as we've started to research this a bit more, what we're finding is certainly resilience is an important component of this profession, but there are emotional and psychological costs to internalizing that grief and doing it with a broken heart every day without processing it in a healthy way. And so that's why I was just so thrilled to hear about Dr. Galanos and the progress that he's helping us make to challenge that culture and really lean into grief as opposed to compartmentalizing it.
I mean, we all know what it's like to lose our loved ones and to grieve. But a lot of us don't know what it's like to be part of watching everyone's loved ones and to think that for our families and friends, when we lose them, we can take a beat, we can grieve, we have a moment. But doctors have to go right back at it, and nurses and all of the clinical staff around them that are supporting patient care.
Yeah, I really like the quote, where there is loss, there is grief. And I think that our culture in general, but especially in medicine, would do well to recognize that reality that we are human beings. And in these moments of transition and loss, there's a natural response that doesn't necessarily have to be completely discarded or stigmatized, that there are ways to process that more healthily, and that actually can make you a better physician, not a worse one.
And a better person.
And a better person. I'd like to introduce Dr. Manesh Patel. Manesh is one of the executive producers of the podcast, as well as a board-certified cardiologist, chief of the divisions of cardiology and clinical pharmacology at the Duke University School of Medicine, and a faculty member with me at the Duke Clinical Research Institute.
Thanks for the introduction, Emily, and I'm excited to be here. And thanks, Tony, for being here. Excited to have you.
Great to be here. Appreciate the opportunity.
Well, maybe we get started by just talking a little bit about how we know each other. I was excited to be one of the residents at Duke when you were and still are one of our star faculty. Tell us a little bit about how you got into teaching about grief and how you came about.
It's really a good question. It's usually not cocktail party fodder. But what happened actually were the house officers, the interns and residents themselves, asked the chief resident if I could meet with them to discuss the hard parts of their work, which turned out to be mostly at that time, this is 12 years ago, mostly at this time were ICU residents who had experienced multiple deaths in a short period of time with no time, as our colleagues said, to process it, but having to move on. So I started debriefs, or 40 to 50 minutes of sitting with ICU residents, talking about what's hard about the work, how they were or were not processing all that had happened to them. And this is now a 12-year-old program that has evolved into talking about clinician grief.
What a real passion project about finding something that we all needed more than we thought. What would you say are some of the lessons or things that happen across the course of starting to do this?
Yeah. So as our colleagues had outlined, we have the best and the brightest. So that's never an issue. Can they memorize? Do they know what to do next? And for the most part, they always do. And certainly by the end of their training, they always do. The part they weren't expecting was watching a younger person die who has 2 children who come to the bedside, watching their nurse colleagues who are usually very young, and by that I mean under 30, and here they are doing end-of-life care when they went into nursing for the passion to help others. They're not ready for this. And the younger the provider, we actually have data on this, the younger the provider, meaning an intern versus resident versus a fellow, the more they express the need to talk about what just happened. And we've created something at Duke called the pause. It actually was started at UVA in their emergency room in the nursing literature. But all the pause is after a code or a very intense resuscitation effort, instead of just moving on to the next task, can we take a moment of silence, no prayer, no singing, no hand-holding, but just a moment of silence to acknowledge what just happened. This is somebody's mom, somebody's daughter, somebody's spouse, and we need to acknowledge what we did to try to save this person, and sadly, it did not work out. It takes 30 to 60 seconds, and then people move on to the next task, which is in the debriefs that I've been doing, as you know, affectionately called G-briefs. My name at Duke is Dr. G, and it's also my side hustle where I sell underwear. But anyway, I use humor to cope, and it has stood me well for 30-plus years. When I do G-briefs, the number one thing the house staff, the fellows, and even fellow attendings have shared is that we have to go on to the next room. And I'm not ready. I'm still thinking about what just happened. And I think the pause has been a wonderful, simple intervention to take a breath, to say you tried really hard. And it is sad to acknowledge sadness. I like what Dr. Brian said, where there is loss, there's grief. Really, it's where there's love, there's grief. Because if you didn't care, and this is what I tell the house staff, people don't recognize how much our kids care. If you didn't care, you'd move on and just do fine.
I guess I'd be curious to hear your thoughts about whether this work is easier now that we seem to have more acceptance of psychological impacts of events and more support for mental health. Far from perfect, but compared with when you started, does it feel like people are more receptive?
I don't think in general we're more receptive yet. So here's the rub with working with doctors. We have lots of data, not that I generated, but national data, be it surgeons, be it internal medicine people, family medicine, peds, oncologists. Doctors won't talk to other people except doctors. They will not talk to chaplains or social workers, and usually not even PhDs. So there's a huge movement, and this might be where the traction happens, to do peer-to-peer. In surgery in Boston, the 3 teaching hospitals have their own peer-to-peer because they don't want to talk to psychologists. They don't want to talk to mental health people. And at Duke, the predominant person speaking candidly is either a master's level social worker or a chaplain. And historically, doctors have not spoken with these people. Though they're abundantly available and willing and skilled. So I think that's where my success has come from, because I'm the only white coat out there. And also, thank goodness, having been here so long, they all know me. So a chief can go to their faculty member and say, go talk to G, and then see where you're going.
I think that's right. And I do want to give credit to Dr. G on the training of generational people that are attacking this, or at least addressing this in ways that we haven't. We do monthly morbidity mortality conferences where we go through the procedure. What could we have done better? What could we do? And now we've started having the conversations in that small room where we talk about a procedure and could you have done this better? Did we talk to the family? How did that go? There are conversations that we didn't used to have when we did M&M conferences, because a lot of it was technical and should you have done this? And those are traumatic times for people because they feel responsibility. But now the conversation's also going into just how we care for the family and each other.
You know, the other thing you hear from providers, be they PAs, respiratory therapists, God bless respiratory therapists and what they did for us during COVID, regardless of our role on the interdisciplinary team, the other thing they ask is, should I have spoken to the family because I didn't? Or I did speak to the family, but now I'm worried about what I said. So I'm happy to suggest to these bright minds that what you say to a family member will be remembered the rest of their lives in that particular moment. I know this because I've aged and I've been there. They appreciate the importance we're now putting on communication after a death. And the second thing I tell them is, this is when you have to be your most authentic self, because all the family cares about really is that you acknowledge their loss. You don't have to have magic words, something doctors feel that they really have to have.
Right.
You don't have to have magic words. If you know the family well enough, you can touch them, you can hug them, and it all says the same thing. I'm sorry for your loss, and I acknowledge that this is an enormous moment.
You know, you described what we've done for residents and students, but there's also a cultural change going on with the faculty or the physicians, right? So what have you seen happen there?
Well, I'm happy to...
Or other healthcare providers, not just the physicians, right?
Well, the other healthcare providers have been wide open to this. I can't keep up with the talking
demand.
gigs. Tonight, I'm speaking to the oncology advanced practice providers in Raleigh, for example. I'm happy to report, particularly to someone like you in your position as chief, that the attendings are now opening to this type of intervention, just meaning a debrief, not therapy, not you did well, you did poorly, actually just space and time. I call it grace and space to process what happened to you and how the big R, how much responsibility you feel as the attending. This is taking off. It took a while, but now attendings are debriefing with just other attendings and just asking simple questions like, when that young woman died and you saw those two young kids go in the room, and of course there was a chaplain there and all kinds of family, what did you do when you went home that night? That has proven to be an aha question. I've heard everything from, I felt like maybe I should consider quitting medicine, to running the tape over and over. Did I miss something? To, and this is the most common response, my children are the same age. That combination of personal and professional, we've never acknowledged that doctors might have a life outside of the hospital, and that life may trigger things that happen in the hospital and vice versa. I know that's very true of me after 35 years at Duke, and this is powerful stuff. As our colleague said in the intro, we just haven't acknowledged it or talked about it.
Yeah, you've done an amazing job in helping us talk about it, have the conversation. Are there things we're doing to start to learn about it, what's working, what's not? This is a place as a group that wants to learn, we often talk about. And we've done studies in palliative care. We've even got a service to help people as we think about it.
Yeah.
I know you round on that service.
Yeah.
Tell me about where you think the state of the science, if you will, is in this space.
Let me pull a Duke attending on you. I started that service
Yeah, I love it. Yeah.
in 1998. But you can send me a check later. What we're starting to do, because the currency at Duke and all academia is publications. I'm very proud of a certain cardiology fellow named Dan Lorio, who 2 years ago, he and I put together a survey, got IRB approval, you know the drill, and we have surveyed residents and fellows in the ICU setting. Have you felt grief in the 6 months? Was it personal, professional, both? What did you do? Did you attend debriefs? How many? Were the debriefs helpful? Dan found that in the ICU setting at our shop, which, as you know, we have more ICUs than most hospitals have beds, he found 87% of providers self-reporting personal and professional grief. Didn't surprise me, but it is now sitting at the Journal of Critical Care Medicine, and I hope that manuscript gets accepted, because we need to publish that this is not just good-hearted, we like to hold hands and sing Kumbaya. This is how you retain physicians. This is how you mitigate burnout. This is how you keep happy employees around an ICU setting where they know 6 hours from now, I bet I go through the exact same experience.
Yeah, and it's also how you train the next generation. This is one example. I will say that it's not surprising to me that you started the palliative care service in 1998. It's quite a forethought. As you talk about that, one of the things that I'm sort of struck with is we are changing this perception that grief means doctors are human, and if they're performing in a human way, sometimes they're not going to perform as good as they're supposed to.
Yeah.
How are we changing that conversation from that to saying being human and being human in the moment might make you?
Yeah. So the first skill interns learn is compartmentalization.
Yeah.
If you cannot compartmentalize, you're not going to last in nursing, medicine, respiratory therapy. So in the moment, you need to give that patient and that family 100%. Well, what happens, and this does happen, if a code is called in the room next door or across the hall? Well, you respond to that, and you have to be able to put what happened in room 1 in a box for now, and then go to room 4 and do your best for that patient and family. I also run narrative medicine for the Department of Medicine. I'm impressed with what our young doctors write about. This senior medical student wrote a poem where she talked about after something bad happens, and she had just rotated in the ICU doing her sub-internship in preparation for applying to residency. I put things in a box, but one day I went home and the boxes were too high. And one day, all the boxes fell on my head. Okay, this is where honest communication, sharing with your peers, if you need therapy, go to therapy, but there's more room on the outside. So it's great to learn how to compartmentalize, but do not do that at the expense of never sharing. So what's happening is these kids with 150 IQs, and they're learning that it's not only okay to share, I better do it.
Yeah, to stay healthy and to do the
stay
right
healthy
things.
and to be present for the next family.
This is Beyond the Endpoint, a podcast where we bring personal and expert perspectives on healthcare and clinical research to the casual listener. Stay tuned after the interview for a breakdown with the hosts. They'll talk through key takeaways and what this week's topic means for you.
So you talk about younger doctors wanting to learn.
Yes.
How much do older doctors need to unlearn? Because I think the flip side of compartmentalizing is, I would imagine, it could lead to burnout. Anger,
Yes.
it could harden into anger, it can
Right.
harden into burnout,
Yes.
and it can lead to, not great medicine. So in some ways, you've got these expert older doctors.
Yes.
How do you reach them?
So the blessing is the older doctors get it. It's the doctor in their 40s and 50s who are making their careers. He needs you. Okay?
He needs you.
Yes.
Yeah.
No, he needs all of us.
Okay.
Because he's not sharing anything.
Well, you've shared a lot about how we think about it for our doctors and healthcare staff, or nurses, respiratory therapists, a lot.
Yeah.
How do we take some of these lessons and think about the families or the people that are trying to navigate the grieving process in the moment, people listening who are going to get an insight into what it's like in the health system, but who are also going through this process?
I love that question because the patient and family, as you know, are our focus. I think our society in general, and I'm not a sociologist, so I want to temper my remarks, but if the only time we talk about death and dying is right afterwards, if our greatest source of education about end-of-life care is Hallmark, we're in trouble. And I like it that my daughter, who is a PA, she said, do you ever get tired of talking? I mean, is this healthy? And I will say to her, and I've actually been fortunate to lecture by Zoom to her PA school up in Illinois, if we don't talk about it, if we don't make it part of the fabric, we're hurting our patients and families who get a week or two of sympathy, maybe a week off at work because most bereavement policies are not generous. Then these people are left to grieve in isolation. And the only thing worse than grief is being by yourself.
Yeah.
So the other thing I do, I'll just pass one pearl, is when I did palliative care consults, I would tell family members, in 6 weeks, check on mom or dad, because by then all the cards will have come, all the pound cake will have been eaten, but that's when it's going to hit them, that their house is empty.
Yeah.
And that the silence is powerful. So in 6 weeks, your homework is go pick your mom up and go to Disney World.
Yeah, well, I'd say some of the stories you've helped us with, I'm going to share a story you did for us in the division, which was quite powerful. We had a family member, I'll call him family member. We had a faculty member who we see as our family member who was unfortunately in a car accident, lost some family members of his and had a tremendous grief. And we were struggling as a group of professionals to say, we've had a member go through this. How do we support them? And then how do we internally grieve? And I remember I had you come give a cardiology grand rounds. Maybe you'll share sort of the lessons you shared with us there.
It's a tough situation because, again, since we don't talk about it, we don't really know how to support a faculty member when they come back. I think the one thing we should acknowledge and give the griever benefit, regardless if they're a tough doctor or, a touchy-feely social worker like my sister was, whatever our stereotypes are, they are not the same person they were before the loss. And they're going to come back probably too soon, and they're going to realize that not only emotionally are they different, but even cognitively, they're stunned and can't quite generate it. So what I've done with faculty members who've had terrible losses, and sadly there are a number, is this is what I want you to look out for. And if you came back too early, please have the grace to tell your chief, your immediate boss, I made a mistake. I personally had a big loss, and my boss did what all bosses should do. He came and told me, take as much time as you need, and then did what all bosses do. But just for planning purposes, when do you think you might come back? I like to think that I have some wisdom now that I'm 71, but what I said in that moment without preparation was the wisest thing I've ever said. And what I said was, Chief, if I don't come back for 2 years, it'll be too soon.
So
Whoa.
true.
I didn't know that was true, but it turned out to be. And that's why I like being around doctors who've had terrible loss, because there's not anybody on the planet who can tell them that's okay except another doc. Same with the caregivers that are out there. If your spouse dies, you're not going to get over this in 6 weeks or 6 months like all the books say. It's going to take potentially years. And I think if we give ourselves that grace, we serve a much greater good.
Well, Tony, it's an amazing story. And again, I hope, I'm sure the listeners get a sense of just your passion, your commitment to us, our individuals, our patients, our families, from the palliative care service to Grief 101, a medical school course, teaching our fellows. It's been really quite an amazing journey that, of course, we want to continue to support. Is there anything you see going forward, or any last things you think we should know about the work you're doing, or where you think the grief training is going for our field?
Well, I'm very grateful that even my loss has contributed to being of help, of service. You never tell a doctor, I can help you. Of being of service to others. And it also clues me into what other people are going through when they have a loss, be they one of our families in the hospital or a coworker. I think what's coming in the future that I would love your support with is this finally cracking the nut of working with attendings, the role models that we have, and cracking the nut of interprofessional education. So I think there's so many more audiences we need to reach. And then I will retire someday.
Oh, I don't believe it.
But not until we have a succession plan that's viable and running.
We're going to need a lot more Dr. G's. Life is about service and purpose. Thank you so much, Tony, for joining us.
Appreciate the opportunity.
So, Emily, something that's really interesting to me listening to G, as he likes to be called, is as a patient, you want a doctor who cares about you as a human being. You want to know that you matter. You're not just a widget to that doctor. At the same time, you want a really good doctor who's going to be able to focus, do the right thing at the right time for you. Those are two different things sometimes. And I think what we've talked about today is the balance. And what I've taken away from this as a patient is how important it is for me to give space and grace to my doctor when I'm feeling a little widgety, to remember that maybe, that doctor's really trying to do the very best for me. And to remember sometimes that doctors, when they're, there's a lot on their shoulders, and give them a little bit of space and understand they're dealing with everyone's grief. Well, a lot of us are really just dealing with the grief in our own circles.
I love that. I also was really struck by this ritual, very, very brief ritual, the pause, built in to the sort of day-to-day. And I think it's such a nice approach that recognizes that practically we may not have a lot of time to sit down and get into how we're feeling and do the full reflection, but it takes what's hidden and underneath the surface and it brings it up just for a moment, and it allows it to be there and it really welcomes it. It's just such a powerful image that I think is an incremental step against this disenfranchisement of grief that we've seen and been talking about. So one of my takeaways is it seems like those small steps are maybe the way to go, maybe the only way to really get there when you're hoping to see a bigger culture shift, and that they do matter. The anecdotes that are shared in grand rounds and the reactions of attendings to displays of emotional vulnerability. I mean, these are things that students can really soak up and internalize and take with them. So it's just been great to hear so many examples of that in practice today.
It feels like it lessens the moral injury a little bit and possibly prevents burnout on down the road. We talked about the generational differences, and I wonder, that pause in some of these interventions we've talked about with folks younger, earlier in their career can help people who are mid-career where they get to be really at risk.
Yeah, I was struck by the image of stacking up the boxes then having them fall down and recognizing that you can make the choice to push it away, but there are potential consequences to that. So it's important to take steps to unpack those boxes a bit before they become overwhelming, and that you're actually not only doing yourself a service, but you're developing skills and resilience that will then help you be a better doctor and translate it hopefully into better patient care. So I think those types of images, the more that we can work them into training and acknowledge them as an important part of the experience, I think the better for our students.
I agree. It also strikes me that we as a society went through this very brief period during the COVID pandemic with healthcare heroes, where we were really boosting them up. And that kind of, it only lasted for a bit. And somewhere in between hero and, oh my goodness, why can't I get an appointment? And why isn't this doctor calling me back? And why aren't they doing this? And I'm so frustrated. Like that space in between that we as a society need to make sure we're supporting and giving space to our providers all the time, not glorifying them one minute and criticizing them the other.
Yeah, I think that the hero term was well-meaning, but it's also complex. I think one of the major downsides of it is it implies some sort of omnipotence, right? I mean, like these people are bulletproof and they can work these 24-hour shifts, and they're there no matter what happens. It's a pandemic. We can count on them, and they're still people. And I think what we saw through a lot of the data that we collected in the Hero Registry that we worked together on is that, like, not only are there people, they have complex and diverse experiences with grief and with trauma and with crisis. And for some people, it shows up as anger. And some people, it shows up as burnout. Some it shows up as moral injury. And that those manifestations really should be respected and honored and treated with care through peer-to-peer, accessing other resources. But it's not as simple as, oh, let's turn it over to the perfect, all-powerful hero.
That's right.
I think certainly they are powerful people. They have a great deal of skill to offer, but they're still people and they have emotional needs just like the rest of us.
Thank you for joining us for this week's episode of Beyond the Endpoint, and to Tony Galanos and Manesh Patel for this fascinating discussion on grief in the clinical setting.
We'll be back in a few weeks with our next episode, where we'll be talking about hypertension. The future for hypertension doesn't look good. What can we do to bend the curve? We'll break it down. See you then.
This has been Beyond the Endpoint. Resources related to this episode are available on dcri.org/BTE. If you have any burning questions about clinical research or healthcare, drop us a line at beyondtheendpoint duke.edu. We'd love to address your questions in a future episode.